Dear colleagues, this is a hard cataract with mid-dilated pupil. In such cases, I do vertical chop, and I suggest that you also do the same because it may not be safe to go underneath the iris near the equator of the cataract and attempt horizontal chop. In this case, by this time a main incision has been made and two stab incisions also have been made. Now in this case I have planned to stain the anterior capsule of the cataract with trypan blue dye and use adrenaline to see if the pupil dilates a little more, or even if it doesn't dilate, if it maintains this size of the pupil, then it will be easier for me to complete. This is the adrenaline, and trypan blue dye has been placed just before this. Now everything is washed out with BSS. That's it. Now viscoelastic substance is to be injected into the antechamber. I use HPMC, hydroxypropyl methyl cellulose. That's it. And now is the time to use a cystitome for incising the anterior capsule of the cataract. Here it is. The capsule is incised and a nice flap is raised. This flap is held with a utata forceps. This is a very thin utata forceps. It is held with this utata forceps, and I go along the border of the iris so that I get almost 5.5 millimeter rhexis. That's it. The rhexis has been done. Now hydrodissection is done. I be on the anterior surface of the cataract, slide the cannula over the cataract, go underneath the anterior capsule and do the hydrodissection. A little bit of decompression and nuclear rotation is done. Nucleus is free now from the capsule, and now it is the time to enter into the eye with the tip of the phacohanthus. In this case, I'm going to use Oatley Cataracts 3 phacoemulsion. Here it is. And in this case, I have planned direct vertical chop. Here it is. I impale the tip deep into the nucleus and I go deep and I do the vertical chop. That's it. It is done. Rotate the nucleus and divide this heminucleus into two big fragments. That's it. Done. Now I rotate, hold this fragment and separate it, make it free. Now hold this another heminucleus and divide it into two fragments. That's it. The nucleus has been divided into 4 large fragments. The phaco power in this case was 80%. Flow rate is 45 ml per minute and vacuum is 450 mm of mercury. Now each fragment is worked on and each fragment is emulsified and aspirated. So if the pupil is of this size, about 5.5 millimeter, or 6 millimeter, it is not difficult to handle such cases. We just have to be patient, and when the surgery goes for a long time, we must come out and inject some viscoelastic substance to protect the corneal endothelium. Because I'm using HPMC, and HPMC will not stick to the corneal endothelium as firmly as viscoat, that is chondroitin sulfate. So I come out, inject some HPMC, and this small nuclear fragment is removed by depressing the posterior lip. Then I go again into the anterior chamber with the tip of the phaco handpiece. This fragment has been dialed and it has been placed in such a manner that I can easily engage the tip of the phaco. Now I attack from the apex. When it's a long fragment and it has got a sharp apex, one of my gurus have suggested me that I should attack from the apex so that it doesn't push the posterior capsule. If the equator is resting on the posterior capsule, it is not going to pierce the posterior capsule because the force will be divided on a large area. That's it. The nucleus has been managed, and now is the time to remove the epinucleus and the cortical matter. When the pupil is small, I feel comfortable using a Simcoe cannula. When I cannot see the cortical matter, I can use my sixth sense in a better way with a Simcoe cannula. This is a very slender, nice 23 gauge Simcoe cannula, and I can use it through the side ports. The side port incision is little larger, 0.2 millimeter more than the size through which a bimanual IA can go. Now viscoelastic substance is injected into the antechamber and a hydrophilic acrylic intraocular lens is implanted in the capsular bag. Dear colleagues, to be a fine and safe surgeon, we must keep our reflexes very sharp. We must keep an eye on everything, all the surroundings. Where is the posterior capsule? We must develop a very good depth perception. We must practice some hand movements in the air. We must practice making rexes in the air. Now viscoelastic substance is thoroughly removed from in front of the lens, from behind the lens, and thorough cleaning of the viscoelastic substance is a must to prevent post-op rise of intraocular pressure. When the intraocular pressure is prevented, the patient is very comfortable. If the intraocular pressure remains normal, next day patient will give you a very grateful and joyful smile and you will feel happy. But if the patient is having pain in the night, if you see steamy corneal edema next morning, your great surgery will be having a very sad end, although it can be controlled with medications. Thank you very much for watching. Hope to see you in the next video. Hope these videos are being useful in your practice.